So it's my honor to introduce our two speakers for this afternoon. Dr. Jane Brock is the Chief of the Breast Pathology Division and the Director of the Breast Pathology Fellowship Program of Brigham's and Women's Hospital, and she's also the Associate Professor of Pathology at Harvard Medical School. Our second speaker is Dr. Julie Graylow. Dr. Graylow is currently the Chief Medical Officer and Executive Vice President of the American Society of Clinical Oncology. She is the founder of the Women's Empowerment Cancer Advocacy Network and supports patient advocates in low and middle resource countries. She is the recipient of the 2018 ASCO Humanitarian Award for her work in empowering women cancer patients and survivors globally. So Dr. Graylow and Dr. Jane Brock.
Thank you so much, Roselle. If we could have the first slide. Today, Dr. Brock and I are going to be discussing two markers. One, Ki-67, and then another that we had some discussion about yesterday, this new Her2 low category. So we're going to start where I will give a little bit of the clinical background on the marker, and then Jane will give the pathologist perspective, and then we'll come back and address the next marker. So let's talk about Ki-67. Ki-67 is a marker of proliferation. And I'm starting here by orienting us all. When a patient is diagnosed with breast cancer, we need to know certain things about the cancer and certain things about the patient in order to make the best treatment recommendations. And some of the things that we take into account are the stage of the cancer, how large it is, how many lymph nodes are involved, and whether it's spread beyond the breast. We need to know the estrogen and progesterone receptor, Her2, the tumor grade can be important, proliferation status, Ki-67, which is what we're going to focus on now, and we have some other markers that we can use. From the patient perspective, age can matter. Menopausal status certainly matters. The patient's other health issues can play a role in our treatment decisions. The patient's personal goals and choices and preferences, and sometimes the patient's inherited genetics as well. So let's talk about Ki-67. It's this marker of proliferation. And what is proliferation? It's cell growth, it's turnover, the cell is replicating or proliferating. So Ki-67 can have a role in prognosis. It's associated when it's very high and the cells are proliferating and growing, it can be associated with a higher risk of recurrence. And also sometimes we use it to distinguish between two different types of estrogen receptor positive breast cancer that we call luminal A and luminal B. And that's probably something that's less relevant to patients and more relevant to the oncologists here. Now, Ki-67 can also be a predictive marker, and that means that knowing if it's high or low may tell us how we can treat or how we should treat the patient. So in the absence of some of the more expensive multi-gene assays that are out there that we use in the United States, Ki-67 can be used with estrogen receptor and grade and the size, et cetera, to decide whether or not the benefits of chemotherapy outweigh the toxicities. So that's a potential role. Also, in the U.S., we have an approval using the Ki-67 level that's done on the tumor that tells us whether we can use a certain cell cycle inhibitor, CDK4/6 inhibitor, abemaciclib, in early stage breast cancer. And then I'm going to show you a little bit about a trial that was presented at the ASCO meeting this past June on could we pick out women an older population of women who have had a lumpectomy who don't need radiation after the lumpectomy. So I'm just going to show you from the ASCO guideline that was just updated a few months ago on biomarkers for early stage treatment of breast cancer. The ASCO guideline clearly says what I just had said. In the absence of having these multi-gene assays such as Oncotype DX you may have heard of, or MammaPrint, Ki-67 could play a role in deciding whether or not the tumor and the patient are going to benefit from chemo. This ASCO statement also says Ki-67, and Dr. Brock's going to talk about this, it's most helpful when it's very low or it's very high. And there's this middle range where it's not terribly helpful. And so those are some recommendations that come from ASCO. And also, we've got some prediction. This is from the National Health Service out of the UK that is looking at predicting risk of recurrence, benefit from chemo, benefit from endocrine therapy, etc. And I just put this in here to show you that this risk prediction tool does put Ki-67 in if you know the answer. So let me just talk about the one approval in the United States that we have that uses the Ki-67 value to determine if there's benefit from adding a drug, that the drug abemaciclib, a cell cycle inhibitor. This is the MONARCH-E trial. It was a study of patients with early stage non-metastatic breast cancer. The tumors had estrogen receptor expression and they were lymph node positive. And everybody finished their chemo and radiation if they were indicated. Everybody got endocrine therapy, and then there was a randomization to a CDK4/6 inhibitor, a cell cycle inhibitor, abemaciclib or not. And the results of the study, and we won't go over all these numbers, it was evaluated with 19 months of follow-up and again with 27 months of follow-up. And in both cases, there was a benefit to adding the abemaciclib. This just shows it here. It was a small benefit, just a few % difference, but there was a statistically sound benefit. Now, we still haven't shown an overall survival benefit, though. The patients aren't living longer. So it was positive for its main endpoint. How long did the patient go before the tumor recurred, the disease-free survival? And so what happened was they went to the FDA and said, can we get this drug approved? And the FDA looked at all the data, did a secondary analysis, and determined that it was really, at least with the data that they had, only the group that had a Ki-67 that was high, 20% or greater, that seemed to be benefiting from adding this drug. So the U.S. FDA's approval is if the patient has an early stage breast cancer that has positive lymph nodes and the Ki-67 is 20% or greater, that we can use abemaciclib. Now, it's an expensive drug, and it's not even used in that setting all the time in the U.S. And so that is one indication for Ki-67. And very quickly, this study was shown at the ASCO annual meeting. It was a study run out of Canada for women 55 years of age or older, which is a younger population. In my mind now, the older I get, 55 as a cut point is not necessarily defining elderly women. And they all had small tumors, so they were about 2 centimeters or less. And they had to have at least some estrogen and progesterone receptor expression. Her2 had to be negative. They had to be grade 1 or 2. They all had to have had breast-conserving surgery, so a lumpectomy. They all had to be receiving endocrine therapy. This is really important. They all had to have some anti-estrogen therapy. And they then asked for a block of the tumor, and in a central lab ran Ki-67. So this is an important point, and Dr. Brock is going to get to how it's difficult to reproducibly do the Ki-67 assay, they didn't trust in this assay that the little local labs would be doing the Ki-67. They wanted it to be done in a central lab. And I don't know why they picked the cut point of 13.5%, but if the Ki-67 was less than 13.5%, meaning less than 13.5% of the cells in a given field out of 100 were replicating, then they didn't give them radiation. So it wasn't a randomization to radiation or not, they just didn't give radiation. And then after 5 years, there were only 2.3% of patients that had a recurrence in the breast. So lumpectomy, getting anti-estrogen therapy, no radiation, and after 5 years, a very, very low recurrence rate, 2.3%. So the conclusion of the study was that we can define a group of women who probably don't need radiation after lumpectomy and do very well. And my question would be that even though they estimate that this could save, just in North America, 30,000 to 40,000 women from needing radiation, my question was, did Ki-67 have anything to do with the outcome? This was a low-risk group. They were small, node negative, good features. The study didn't prove at all that you needed to run the Ki-67 on top of all of that. So I would say, absolutely, we know we can find women who don't need radiation after a lumpectomy, but I don't know that Ki-67 had anything to do with it. So now, just to summarize the possible clinical roles I've already talked about, maybe we can use it to decide who should receive chemotherapy. We definitely, at least in the U.S., can use it to get approval to give a cell cycle inhibitor to a group that has a very high risk, lots of nodes, and I don't know that we need to use it to define who needs radiation. And I'm going to turn this over now to Jane Brock.
Thank you, Julie. This is excellent. Okay, all right. Oh, I haven't got my slides. I can't see my slides.
It's the same slides.
Yeah, but I can't see them. Can you get my slides to show up on there? Thank you. Thank you. Okay, so Ki-67 is a nucleostain when you do immunohistochemistry, and it's expressed throughout the active phase of the cell cycle. So it's when cells are growing, when they're replicating their DNA, and when they're undergoing mitosis and splitting up. We measure the Ki-67 by saying the number of positive cells as a proportion of the total tumor cells. Many more cells are Ki-67 positive than are actually going through mitosis. So that's an important point to realize. It measures more than just mitosis, but it does correlate with mitosis. And of course, mitoses are one of the most important parts of tumor grading. So when we look and compare Ki-67 with mitoses, they're very similar, with low levels having a good prognosis and high levels of mitosis, and Ki-67 having a poor prognosis. But when it comes to doing Ki-67 immunohistochemistry, we have a huge number of challenges. First of all, we can't compare Ki-67 between clinical trials because trials very rarely use exactly the same method of scoring when they're evaluating the Ki-67. And even despite many, many years of using Ki-67, we still do not have national or international standards for what is low or high. For example, is it 20% or 30%? And even in our latest trials, we have disagreement. The MIB1 antibody has been around forever. It's kind of old-fashioned, and it's not very robust. So, in other words, if you have a prolonged cold ischemic time, if your tissue doesn't get into formalin quick after you've taken it from the patient, that Ki-67, the protein degrades and you get loss of expression of Ki-67. So it's common to see low levels in excision compared with the core of the same tumor. The other thing is when you're comparing manual scoring with digital imaging scoring, you'll get higher results with the manual, but that doesn't mean that the digital imaging isn't bad. It's actually got a pretty good correlation and reproducibility with digital imaging scoring. So knowing all of these problems with Ki-67, an international working group, the International Ki-67 Working Group, set about trying to standardize and to basically perform studies to standardize our evaluation. So if you were to summarize 10 years of work in 4 lines from the Ki-67 Working Group, they basically said, hey, when we read Ki-67 in tiny little pieces of tumor, TMA tumor, we have very poor correlation. If we train and standardize the method of doing it, we significantly improve that correlation. When we go and look in real life at whole images, we have to start from scratch again, because all of a sudden you have variability in Ki-67 expression across a tumor. And so, for example, in this picture here, in this picture here, you can see that there's a lot more staining at the top of the image than there is at the bottom. And so you get variation in expression, you get hotspots. And so it's really hard to know what the best way is to do it. And so the working group has finally decided in 2018 that the global scoring method was the best, and that was comparing it with a scoring method that used a lot of paying attention to hotspots specifically. So when we look at the method of the global scoring method, I'm only going to say this quickly to sort of emphasize to you how awful this method is. Basically, you have to divide your tumor into 4 parts. You have to divide it into negative, low, medium, and high expression. The next step is to take 4 high power fields, one of each of those intensities of staining, and score them. You score them with a typewriter method, which I will show you, until you've counted at least 100 cells, or all the cells in your field. Then you do a complicated bit of math to get your Ki-67 result. So here's the typewriter method. You basically read along, looking down the eyepiece of your microscope. I am incapable of doing this. Every time I look down a microscope to score Ki-67, I fail miserably. I actually have to print out pictures of Ki-67 stain slides and with a pen count them off. I can't do this method. The other thing that I think is really important in this is that the Ki-67 Working Group published this series of pictures of what they call positive, and it's kind of shocking. So in the top, on the left panels, you'll see that there is very, actually that's not going to show up, is it? My laser point isn't going to show up, never mind. On the left-hand side panels, you'll see dot-like staining, really weak staining. I would never call those cells positive, and yet the Ki-67 Working Group want you to call those positive for scoring Ki-67. The ones on the right, I have no problem calling those positive. So that's a really important point for how difficult it is to decide what is positive and what is negative. I'm showing you here the algorithms that you use just to show you that you have to be good to be at maths to be a pathologist. They do have an app that actually calculates this for you, but it's not currently downloadable, so good luck scoring it. You know, they actually published, the working group published an update in 2021 that basically was, yes, we acknowledge that it's really tedious scoring Ki-67, that it's, there's still problems with variability, and as Dr. Graylow mentioned, the problem is all right at the cut point that we actually care about, between 10 to 20%. Low scores and high scores are easy, they're robust, and they're reproducible, and you can trust it probably when your lab gives you a score that's low or high. They also recommended doing EQA, external quality assurance. In other words, getting someone else to check whether you actually do a good job scoring. But there's no national or international standards available. So, all that said, how did the 2 big trials that Dr. Graylow talked about actually score their Ki-67? So in the Lumina trial, remember that was the radiation therapy, emitting radiation therapy trial, where you had a 13% cut point. We had to go on, well, 13.5, we had to go above or below. They used the Ki-67 working group method, but they didn't state which one, and the Ki-67 method has changed twice in the last 10 years. I'm guessing, based on the time at which they actually collected the patients, it was the old scoring method, not the global scoring method, and that method was 3 high power fields, count 1,000 cells, and include hotspots. Not the current method. When you look at the Monarch E trial, remember the cut point here was 20%. Above is high, below is low. How did they score it? Well, at first, they didn't tell you how you scored it. It took a little while for us to find out. They did say they had excellent overall agreement, 95% scoring that when they first published this data. But it took until April this year for them to actually publish the method. And it turns out the method is not the Ki-67 working group method at all. They counted 200 cells, a minimum of 200 cells. They, most importantly here, had a very different cut point for what they would call positive and negative. Any tiny bit of staining they weren't going to count. They wanted the whole nucleus to stain before they would count it. So for example, this is a beautiful picture from their publication. Can you see that an awful lot of these cells have got a little bit of brown staining in them? This is super hard, right? I look at that and you go, I have no idea what to count as positive and what to count as negative. So they taught their 3 pathologists how to do it. And they said, the black arrows are negative, the green arrow there is positive. So when I quickly eyeballed this, I got 2 completely different scores, right? So if I score it with the Monarchy trial ruled, I would get less than 5% positive on this one. But if I scored it by the Ki-67 working group method, I would get over 20% positive. So I think that beautifully illustrates how difficult it is to score Ki-67. In the interest of time, I might skip over their validation method. Suffice to say that they had excellent concordance between their 3 pathologists doing this, which I find hard to believe, but that is what they did, and there you go. So in conclusion for the Ki-67, we really still cannot compare Ki-67 across clinical trials because the methodology is still not consistent and it varies. I think we're always going to have a lot of inter-observer variability in that key 10 to 20% range, and I do think less than 5% and over 30% scores are pretty robust, and you can trust your lab when they call in that. And I think at that point we shall move on. Thank you.
So we're going to have discussion and take questions on both the markers at the end. And now I'm going to review some of the clinical relevance of this new category we talked about yesterday called Her2 low. And in the interest of time, I'm going to assume that most of you probably saw the presentation from yesterday, but I'll make the point again, and I showed this slide in the next slide yesterday, that up until a few months ago, we had a category we called Her2 positive that was about 15 to 20% of all breast cancer. And that meant there was an immunohistochemistry of 3+, or if it was a score, immunohistochemistry score of 2+, you had to then confirm it by using gene expression, a positive in situ hybridization. But the majority of breast cancers were considered Her2 negative. And I just show you here what the treatment options were. For Her2 negative, it varies depending on whether the tumor that's Her2 negative is hormone receptor positive or hormone receptor negative. Now, in the U.S. anyway, we have 8 drugs that target Her2 that are FDA approved that we can use. So for the 15 to 20% of breast cancers that we've called Her2 positive, we have 8 different treatment options. And I showed you yesterday the Destiny Breast 04 trial that showed in this kind of intermediate group now that we're calling Her2 low, that at least one of these 8 drugs does have activity. But I make the point here in this slide, we had a prior trial looking at a Her2 low group, which means that the immunohistochemistry wasn't 0, but it was 1+ or 2+, and if 2+, the in situ hybridization was negative. Now, we had a prior trial with the first Her2 drug approved, trastuzumab or Herceptin, and it was outright negative. There was no benefit in this Her2 low group. So we went back to saying Her2 low is irrelevant. We're just going to use Her2 a high, positive or negative. And this shows that study. It was called the NSABP B47 study. Early stage breast cancer, this low Her2 range, everybody got chemo, half got trastuzumab added, and you might not be able to see it, but there's a blue and a yellow line there. They absolutely override each other. There was no difference, no benefit. at all from adding at least trastuzumab. So going back now to creating this new group, we have a drug called trastuzumab deruxtecan, TDXD. It's been approved in the U.S. in the treatment of metastatic breast cancer. That's HER2 positive. It has good activity there. There was some preliminary data suggesting that it might have value if the HER2 level was lower. So the trial, the DESTINY-Breast trial, was designed to test this antibody drug conjugate. So it's essentially trastuzumab, the antibody, linked to chemo. So the antibody brings it to the surface of the cancer cell, it gets internalized, and you've delivered chemo inside. So the DESTINY-Breast04 trial I showed you yesterday, we're now taking this HER2 low group, not the 0 and not the clearly positive group, and these were patients with metastatic breast cancer. They had had some prior endocrine therapy if ER positive. They had had 1 or 2 lines of chemo if they were triple negative, and that you could have your choice of one of 5 different chemo agents, or you were randomized to this TDXD antibody drug conjugate. And I showed all of the curves yesterday, but there was a clear benefit in terms of what we call progression-free survival, how long the patients went before their tumor started to grow again, favoring the TDXD. It was superior to chemo, and the same thing for overall survival, how long the patients lived, with about a 6+ month difference in survival overall. So I will also point out now, so we've got this drug, it's approved in the U.S. for this HER2 low group. How do we know what HER2 low is the next question. And of course, there's another trial to look at. We call it the DAISY trial. And it used the same drug, trastuzumab deruxtecan, TDXD, and it took any HER2 status. So you could be tumor could be HER2 0, 1+, 2+, 3+, whatever. And I've circled here, there were responses in a group that we would, at least with our current assays, call HER2 negative. And Dr. Brock is going to get into why that might be, but could this just be a false positive result? Could there be some cells that had HER2 expression and some that didn't? Or could it be that almost all breast cancer cells have a little bit of HER2, and you just need a little bit for this drug to work? So the FDA has approved this drug in the HER2 low group. ASCO has said yes in the HER2 low group. It's reasonable to use. And it is a new treatment option now for this HER2 low group, which is 45 to 55% of all breast cancers. But we're left with questions. So we've got this new drug, trastuzumab deruxtecan. It is a new treatment option for about half of all metastatic breast cancer patients, but it's not translatable to the other 7 drugs that target HER2. We know for a fact that it's not translatable to trastuzumab. And it has toxicity. I talked about that yesterday. Even though it was compared to chemo, it's not necessarily more benign than chemo. It has some toxicities that are worse than chemo. Exactly where we're going to use it isn't clear yet. And we have the issue of its cost and its accessibility in low and middle resource settings. And then I'll hand it over to Dr. Brock to talk about, we do need to reconsider breast cancer pathology and HER2 testing now, but we don't know how low we can go. And the reproducibility in that low category is unclear. We also have trastuzumab deruxtecan with positive results in colorectal cancer, stomach cancer, lung cancer when it's high HER2 expression. So the question is going to be, will this drug work in that low category for these other types of cancer? And will it be accessible in the earlier stage breast cancer settings? So I'm going to turn it over now to Dr. Brock to talk about what we're going to do with figuring out that HER2 low category, and if it actually matters.
Thank you. All right, so just a quick recap of how the trastuzumab deruxtecan works. It's your trastuzumab antibody tied to deruxtecan, which is a topoisomerase 1 inhibitor. And so when the antibody-drug conjugate binds to the HER2 receptor on a cell, it gets internalized and it tracks to the lysosome, and that's where it gets broken up into two halves. The one half, which is the deruxtecan, and the other half, which is the trastuzumab. And it's the deruxtecan that does the bad stuff. It goes straight into the nucleus, it messes with your DNA, damages it, and it triggers the cell's suicide pathway, the apoptosis pathway. So the cells basically explode on themselves and die. But that deruxtecan is not done at that point. At that point, it then leaves the cell, and it can go straight into the cell of the adjacent, through cell membranes into the adjacent cell, and it messes that DNA up and that cell also commits suicide. So that's basically called the cytotoxic bystander effect, which is a really important part of the deruxtecan trastuzumab antibody-drug conjugate and why it works. Other points about the deruxtecan itself is that compared to TDM1, there's more deruxtecan per antibody, so it's more potent. The other thing is that it's supposed to have a shorter half-life, and what that means is that in theory it's less toxic, although there is certainly lots of toxicity associated with the drug. So basically this drug is perfect for tumors that have lower levels of HER2 overexpression. These are typically the heterogeneous tumors, the tumors that have low levels of amplification around, an amplification score of a ratio of 2 or 3, which we know don't usually respond brilliantly well to HER2, traditional trastuzumab HER2 targeted therapy. So what's the difference between a HER2 low and a HER2 negative cancer, and do we care? Obviously, from Destiny Breast 04, it was HER2 1+ and HER2 2+ that they were looking at. But we know from the DAISY trial that Dr. Grelo also showed you that we got a 30% response rate in HER2 negative tumors. And so ongoing now is the Destiny Breast 6 trial, which is including a HER2 negative cohort. So the question is, why on earth are HER2 negative 0 tumors responding? And we can actually look at this and we can answer this. It's actually really quite neat. So if you think about a HER2 positive tumor, right? It has at least 4 copies of HER2. It's amplified. It has hundreds and hundreds of thousands of HER2 molecules on that cell membrane. When you think about a normal cell with just 2 copies of HER2, it's not that it doesn't have HER2 on the cell membrane. It absolutely does. It has somewhere between 20 and 50,000 HER2 molecules on that cell membrane. But clearly that's not enough. When you have that deruxtecan trastuzumab, clearly that's not enough to get internalized and kill that cell off. Otherwise, every time we took this drug, we would literally die on the spot because it would kill every single cell in our body. There is a lot of toxicity, and clearly there's cells that have higher levels that is accounting for a lot of explaining the toxicity of this drug. But when we think about non-HER2 amplified breast cancers, the more aggressive breast tumors have an awful lot of DNA damage. They have a lot of gains and a lot of losses of their DNA. And so it's actually quite common to have small gains in HER2 without truly being amplified by our conventional standards. And these are the tumors that are being targeted in that HER2 low category. These are tumors that may have 2 to 5 copies of HER2. They can be polysomy. They won't be monosomies because you haven't got an increase in HER2 protein there. And I'm not sure that I've seen any data on ERB2 mutations and whether the tumors that are driven by that will actually have, I don't think they have terribly high or increased levels of HER2 protein. My guess is that they won't respond, but could be wrong. Moving on to the HER2 immunohistochemistry assay and why we've got huge problems with that. So our standard HER2 assay, of course, is the 0, 1+, 2+, 3+, but it was designed to pick up the 3+ tumors really well. It was never designed to discriminate 0 to 1+. And in fact, the concordance with the group that I published with was only 26% discriminating 0 to 1+, but we didn't know we were being judged on our ability to separate out 0 to 1+. So I would say that when you go back and read HER2 reports from a year ago or 2 years ago that was 0 or 1+, you can't trust those results. They need rereading with a much closer eye. And then, So the last thing I want to say is basically, what is the optimal assay going to be for this deruxtecan trastuzumab? Well, clearly our standard assay isn't good enough, and that's because it only picks up the highest levels of HER2 expression, but we want to be able to pick up the lower range between 1,000 and 200,000 HER2 molecules, right? And so we need a completely different assay. We need a quantitative assay for low levels of HER2 expression. I've only seen one publication out there. It's a very recent publication. It's actually a quantitative protein assay specifically looking for HER2 low. It's called the aqua immunohistochemistry assay. They use a fluorescent label and they calculate the HER2 in attomoles per millimeter squared, so it's according to the surface area. And their data is fantastic. So there's a whole bunch of tumors here with aqua HER2 results. And you can see between the two, groups, you've got this low range of expression of HER2. Now, all of those tumors, there's 67% of those tumors have got this low level of HER2 expression by this aqua, but they're considered negative. And a whole bunch of them are actually HER2 negative by traditional immunohistochemistry. Now, we don't know yet which of the ones in that 67% of breast tumors are going, where that threshold is going to be. But if we use this assay or a similar assay, for example, like in the Destiny 6 trial, we'll be able to determine where the threshold is using a much more sensitive assay. So I think that's clearly what's coming down the line. Clearly the Destiny 6 will publish something along those lines as an assay. They have to, they've got no choice. And so wrapping up there, the take-home messages for the HER2 low is that the tumors that are considered HER2 negative are not driven by HER2 as the method by which they proliferate. But it doesn't mean that we can't use drugs to get to, because the cells often overexpress HER2 at low levels, it means that we can use that with the antibody drug conjugates to get that, just literally as a way of getting the drug into the cell and killing off the cells. And clearly we need new assays for that. I'm going to wrap up. Thank you.
Thank you, Dr. Graylow and Dr. Brock, for the presentations. It's really great that you complemented the pathology aspect and the clinical aspect of identifying and knowing the HER2 status and the Ki-67. Historically, for oncologists, when we discuss treatments to patients, several decades ago, we only identify ER/PR positive or negative, HER2 positive or negative. Now we are at that point where hormone receptor positivity is not only just positive or negative. We have to understand the intensity or the intensity of the staining. With HER2, we are not only discussing HER2 negative or positive. We have to identify, is it HER2 low? And aside from positive or negativity status. And now we have Ki-67. Well, we've been using that for quite some time. But the value is not only in the adjuvant therapy, we also have data on the use of Ki-67 determining the status in the neoadjuvant setting as well. So many developments so far that's going on, and having the oncologists here and the pathologists for our patients to understand that breast cancer treatment is not just discussing what drugs to receive, what toxicities that may be experienced, but understanding that the treatments and the management totally rely on the reliability of the pathology. And we will be discussing more about this. We are fortunate to have our reactors, Dr. Jamin Park, Dr. Herdy Luna, and Dr. Cristina Galvez, who is joining via Zoom. And for those who are joining us online, please feel free to send your questions via the chat box. So maybe Dr. Park and Dr. Luna may provide their reactions to the presentation.
Hello, hi, thank you. Thank you, Dr. Barlow and Dr. Brock for the insightful presentations. Just for full disclosure, I actually worked as a pathologist at Baylor College of Medicine about 6 years ago. But then since then, I moved on to healthcare, women's health, venture capital, and a startup scene. So I might be a bit like rusty, so please, I'll try my best. So I think it's really exciting times for Dr. Barlow that you're targeting a woman who have lumpectomy with the anti-estrogen therapy, and some of these women can actually not do the radiation, right? So obviously that, finding the subset of that patient would be very exciting. And I think it'd be very relevant for especially Southeast Asia because as you know, the accessibility to cancer care is quite not as good as the United States. So of course, Ki-67, I've heard about it before when I was practicing. And what I know, of course, back then was that it's a proliferation marker. And of course, there's a better alternative like Oncotype DX, right? Obviously, you can get much better prognosis with other treatment outcome data, etc. So using Ki-67, how is the adoption right now? Do you use this personally for that subset of patients, or is it still requiring a lot of convincing in the oncologist community?
Let's see if this works. No. There we go. So this is a great question. So my full disclosure, I have been out of clinical practice for about 1.5 years now because I took the role at the American Society for Clinical Oncology. But I will tell you, for decades, we ran 4 markers in our pathology lab for breast cancer: ER, PR, HER2, Ki-67. And then several years ago, one of our pathologists said, "You aren't really using the Ki-67 to change anything. Can we stop doing it?" Because it was getting complicated to count and it took a lot of time. And in our tumor boards, they heard that we weren't really, it wasn't in 99% of the cases, we weren't using it. So they said, "Can we stop doing it?" And we had a whole retreat on it and we decided, yes, you can stop doing it. And then 5 years later, we now have the approval of a drug where you need to do Ki-67. So we stopped doing it because we didn't think there was a role. And now we started doing it again, at least in those ER positives that were lymph node positive, where we might have access to this drug. I think we're going to find a better way to define who needs a CDK4/6 inhibitor in the adjuvant setting too. So we'll probably be able to stop doing it again.
Dr. Her2.
Thank you very much. So I'm a medical oncologist, I do clinical practice, and the data, so it's really exciting because now we have more molecules, we have evidence even in different molecular markers, even at HER2 negative, even 0, there's benefit with TDXD. And I feel that this will help a lot of patients in the future. In our setup, it's not very common to perform the Ki-67 as well as add more investigations when you have a HER2 negative result. So this is very practice changing, both for the primary physicians, the surgeons, the pathologists even, to have a second look. Even the team of medical oncologists as well as the cancer specialists to tailor the treatment, not to put the patients into a box that you'll have chemo, radiation, and surgery all together, as well as anti-HER2s. So as more medicines, more molecules come into the scene and the space, the HER2 space, we as physicians need to be updated, and we value these sets of conferences because it's helping each other get updated and to provide meaning, better care, and better information for all patients so that they get better chances. We all know that HER2 is a very aggressive disease, and we need to take a look at those with negative HER2. Even we can provide better care, better opportunities, or better meaning to their treatment. And of course, as physicians, we need to continue learning, keep an open mind, and also put this also, all these evidences, the good, the bad ones, into consideration. And we'll also wait for guidelines so that we can help patients get better opportunities in the future. So this is, again, a very exciting time because as physician scientists, pathologists, researchers, even clinicians work hand in hand. We're helping each other close the cancer gap together. That's all.
Thank you, Dr. Herdy. We have Dr. Cristina Galvez on Zoom.
Hi. Hi, everyone. So sorry I can't be with you. I am truly grateful for our two speakers, Professor Graylock and Professor Brock, for providing us with a very comprehensive but very clear discussion on Ki-67 and HER2 low and its importance in the treatment of breast cancer. So I'd like to touch base first with Ki-67, and thank you, Professor, for both of our professors for discussing it. And I do agree that for patients with high Ki-67 of 30% or more, it really shows that it's a predictor of response or benefit from adjuvant treatment, not only for chemotherapy, but also for targeted agent like your abemaciclib, which is a CDK4/6 inhibitor. Bear in mind, though, that for Oncology Society, according to Oncology Society guidelines, the preferred recommendation for patients with tumor size 5 cm or 0.5 cm and but less than 5 cm, and those having with negative nodes or nodes up to 3 positive lymphadenopathies, still remains to be used the utilization of your multi-gene assays. But I do agree that in the Philippines, most especially, this is not easily accessible. It's only available, I think, in Metro Manila, but not across different cities across the Philippines. And the same goes, I think, for different countries in Southeast Asia. And it's quite costly. It's not covered by by healthcare services. And so we rely heavily on other determinants like your Ki-67. But as a clinician, I do not use it. We do not use it by itself. I agree that it should be used with other factors like tumor characteristics, also including your patient characteristics, and utilizing it together in risk assessment tools, which Professor Graylock also has touched on. But I think the issue really with Ki-67 is number one, with regards to standardization and also reproducibility. And second is what is really the cutoff for a high Ki-67? Some would say 15%, 20%. I mean, there's no argument for Ki-67 above 30%, but there is still an argument for Ki-67 levels between 15% and those below 30%. And second, with regards to patients with HER2 low, again, like what Herdy Luna said, this is a very exciting time because we are seeing breakthroughs in our treatment for especially among patients with hormone receptor positive advanced breast cancers. We have come a long way because I can still remember back then when I was a fellow, the only treatment was chemotherapy and endocrine treatment. And now we are seeing emergence of various targeted agents. And now we have your antibody drug conjugates. And it's truly it's very exciting that now we know that even for patients with having HER2 low, so HER2 IHC scores of 1 and 2 can now benefit from a novel HER2 antibody drug conjugate or trastuzumab deruxtecan. But my question with this is like what Professor Graylock has also kindly mentioned, how about those patients who are HER2 negative? And also, Oh, with regards to patients who are ER/PR negative but HER2 low, because in the study of in the Destiny trial, there was only a very small percentage of patients who were ER/PR negative versus those patients who are ER/PR positive. And so there is something that I still like to ask about that. And again, just like with our ER/PR status, there is still an issue with standardization and reproducibility. I've seen patients having that were called HER2 positive in another institution upon re-evaluation was shown to be HER2 negative and or can be HER2 negative outside but HER2 positive in the institution where I practice. So these are issues that, you know, it still remains, it has been an issue ever since HER2 testing came about and still remains to be an issue, over 10 years. And I'm thinking if Professor Brock and Professor Greylock, if there are already ways on how, you know, globally this can be standardized among different pathologies on how it is read, not only for HER2, but also for ER/PR. Again, thank you for having me.
Thank you, Dr. Galvez, and thank you for sharing your thoughts and your comments. Dr. Greylow and Dr. Brock may respond to some of the questions that Dr. Galvez posed about the cutoff. We know with Monarch E, we use the 20% cutoff of Ki-67 in deciding for patients with high-risk breast cancers to receive adjuvant abemaciclib together with endocrine therapy, and of course the issue of variability in the testing with HER2 and Ki-67. What do we expect? What do the global oncology community would expect in the next years?
Just a quick one on the cutoffs. I mean, the reason we have difficulty is because, of course, it's not an all or nothing. It's not high and low. It's a beautiful bell curve of expression, and you have an intermediate range. And so, we really should have an intermediate range in the same way we have an intermediate grade. We've gone over it ad nauseum.
Right. I think the key point is we need more work on our assays. Medical oncology needs to work closely with pathology to understand this and to have the clinical perspective, the pathology perspective. And I think you brought this up earlier. Every tumor is different now. The more we look and the more we study this, and it's really important to understand all the features of the tumor to get the right treatment for the patient. I think those are the key points.
And there are other markers as well that will be our basis for treatment.
In the metastatic setting now, up until I retired my clinical practice a year and a half ago, in the metastatic setting, I would do genomic profiling. I would ask for additional immunohistochemistry, PD-L1, to tell if the tumor might be responsive to immunotherapy, immune checkpoint inhibitors. And within the genomic profiling, changes, mutations, alterations, amplifications that might give me hints of what drug the tumor might respond for. So we're learning how to do that in metastatic breast cancer, and we're going to be moving it into earlier stage breast cancer. And it's only going to get more complicated, but that's why pathology has to talk to medical oncology all the time.
Great. So that marks the end of our session. We thank Dr. Greylow and Dr. Brock, our reactors, Dr. Jamin Park, Dr. Herdy Luna, and joining online, Dr. Cristina Galvez. Thank you, and we hope this is again another session of learning experience for everybody. Thank you very much, and enjoy the rest of your day.